the numerology. I do believe I take over call from you at noon today. So my hopes and aspirations come true. That's at 2:22. I'll have to give it some thought in the next few hours, what that could possibly be or hope to be. So, but keep me in mind there, Dr. Dan Williams. Anyways, well, good morning, everybody. I am delighted to speak on UPJ management in the next few minutes here. I am also going to apologize to everyone now due to a daycare snafu. I have a dog in the house who may or may not make an appearance either vocally or physically. We shall see. So hopefully not. I have no disclosures. So the goals of today's talk are to, first of all, describe what a UPJ obstruction is, and then review how you can make a diagnosis of UPJ obstruction with the various diagnostic tests, and then identify advantages and disadvantages of the surgical interventions for UPJ obstruction. So what is a UPJ obstruction? Well, as it sounds like, it occurs where the ureter and the renal pelvis meet, that location being the ureteropelvic junction. And it's a functional obstruction of where those things occur. And that matters, as we'll talk about, based on the possible underlying etiologies. Because there are a variety of reasons that you can have the urine not draining essentially as quickly as it's made. So normally what happens when your kidney, your nephrons filter your blood, they create urine and it drips through the nephron into the collecting ducts and eventually drips into the calyces and collects briefly in the renal pelvis, but it's kind of like a collapsed balloon is what I tell patients, that there's a potential space there, but it's usually not full because usually the urine drains pretty much as quickly as it's made. But there are a variety of reasons that might not be the case. So perhaps the most easy for patients to understand is if there's an actual stricture at the UPJ and narrowing that causes a blockage. But there are other possible reasons. So you can have an aperistaltic segment of the ureter. So as we all know, the renal pelvis and the ureter are all nicely lined with smooth muscle cells that help propel urine forward. And for various reasons that we don't understand, there can be a portion of the ureter where those muscle cells are not present or are not functioning correctly, and that can cause a functional obstruction, even if you could pass a scope or anything else you wanted to through the UPJ easily. And then also there can be, as shown in this picture here, a high insertion of the ureter. Gravity is felt to somehow be a part of this as well. So if the urine has to go up to get out, that can be a challenge. And then finally, crossing lower pole vessels is another potential cause. So I do have a few questions sprinkled throughout this talk. We obviously don't have an audience participation option vocally, but I'm sure you're all eager to quiz yourselves in your mind and answer these questions. So what % of normal kidneys, this just came up the other day, have a lower pole crossing vessel? And it's 20%. So these are kidneys without a UPJ obstruction, can still have a vessel there. It's pretty common. So why do people potentially get an obstruction if they do have a separate extra artery going to the lower pole of the kidney? And the answer is we don't exactly know why some people get it and some people don't. But the thought is it's a dynamic process. So this vessel is usually over the top of the ureter and causes a potential kink, but it doesn't always. So it's possible that it could come and go, and it's thought that it's a dynamic process, meaning let's say you drink a ton of fluids, you're going out for your 21st birthday and for your very first time ever having several beers and making a lot of urine quickly. It's thought that perhaps that rapid high flow might change the relationship between the renal pelvis and ureter and that artery and cause a kink that causes an intermittent obstruction. However, the crossing vessel thing is a bit of a controversy. Again, as mentioned, it's present in 20% on CT angios, of unobstructed UPJs, but it is present in between 53 and 71% of patients who are adults with UPJ obstruction, so pretty common. But Lee Richstone did a really interesting study where they sent the UPJ tissue to pathology in crossing vessel pyeloplasties and found that more than half of them, in addition to having had that kink or that crossing vessel there, also had an intrinsic ureteral abnormality such as fibrosis or absence of the smooth muscle cells there. So it's a little bit of a question of chicken and the egg. Does having that crossing vessel there cause some sort of change in the ureter, or does it being there from during development cause the ureter to form incorrectly? We don't really know, but I do know there was in the 80s there was a fad, and so this for taking care of just the artery. So they would do open surgeries on the kidney, but they would just sacrifice that crossing blood vessel and not mess with the ureter, thinking if that's the problem, why would you need to mess with reconstructing the ureter? And unfortunately, it didn't work every time. So that kind of also supports that that it may be sort of more than one problem with the UPJ, even if a crossing vessel is present. So how do patients with a UPJ obstruction present? So as many things in urology and medicine these days, a lot of them can be presenting on incidental findings on imaging obtained for other reasons. So the pediatric folks on the call, I'm sure, are seeing plenty of patients who have prenatal ultrasound findings of hydronephrosis or unilateral hydronephrosis. So we're seeing lots more findings of UPJ, identifying them earlier in life or even before life. But we also see them in adults who undergo CTs or MRIs, any sort of axial imaging. For other reasons, they may be found to have a UPJ obstruction. And those may or may not be symptomatic. The classic symptomatic presentation of a UPJ obstruction, of course, is that of the Diedel's crisis. So patients who may have intermittent flank or abdominal pain associated with nausea or emesis, that classic story of your first drinking episodes as a young adult, hopefully, can be the first sign of UPJ obstruction. Also, it can be found in patients with recurrent UTIs or even stones. So both UTI and stones are seen in patients with urinary stasis, and UPJ obstruction is, of course, a cause of urinary stasis. And then finally, on a workup for renal insufficiency, a obstruction of the kidney that is chronically present and high grade, as we know, can cause some loss of nephrons in the affected kidney. So sometimes they can find that as well. So making the diagnosis of a UPJ obstruction, as I'm going to allude to in the next few slides, often takes more than one imaging study plus your history. So it's hard to walk past an ER these days slowly and not get a CT scan done. So I would say the majority of our patients come to us having undergone already a CT scan. And this will classically show a hydronephrotic kidney with a normal caliber ureter, because the ureter is not dilated from obstruction. A CT scan is helpful for a variety of reasons, including can help rule out other potential causes of hydronephrosis, including stones. If you have stone at the UPJ, it could look pretty similar. And then if a study is done with contrast, especially, although sometimes you can see it on a non-contrast study, you may be able to see a nice lower pole crossing artery, as you can see in this imaging study on a patient of mine right there. And it also may be able to give you some functional information, such as if there's a delayed nephrogram compared to the other kidney, that can be a sign of obstruction. Although since obstruction in a UPJ can be intermittent, that is not a perfect study as well. So another quiz question: which of these drainage times represents the cutoff for diuretic renography, above which the system is considered definitively obstructed? Somewhere between 5 and 30 minutes. This is another phrase for Lasix renal scan. So the answer is 20 minutes. talk a little bit more about that. So diuretic renography is the technical term for what we often refer to as a Lasix renal scan. And the tracer used in this study is MAG3 or technetium-99 mercaptoacetyl triglycine. Say that 5 times fast. So the reason that this tracer is used for scans looking at renal drainage is because it's secreted by tubular secretion. So it really lights up the urine, if you will, which is what you want to see if you're trying to see how fast the urine exits from the kidney. So what happens when this test is performed? The tracer is given and baseline serial images are taken over a 10 to 15 minute period. And then they give a dose of Lasix and then take pictures for another 20 minutes after that. So we get 2 types of information from a Lasix renal scan. We get both relative renal function imaging, because when it's in the tubules themselves, you can see how brightly each kidney lights up, and the computer on the imaging software can calculate the relative brightness of each, which gives us that relative function. I tell patients that each kidney should be pulling half the weight, 50-50. Or technically the ability of the scan to determine is between 45 and 55. But in cases of obstruction, one kidney might be pulling more of the weight than the obstructed kidney. But the other information we get is information about the drainage of urine. So this is an example scan here of a unilateral UPJ obstruction. So again, as mentioned, they give the tracer and they start taking pictures over the initial 5 to 10 minutes. That tracer is going to be taken up by the kidney in the tubules, and you'll be able to see it with the nuclear images. And then the normal kidney, which here is in red, is going to start excreting urine pretty quickly, because as I said, normally the kidney excretes the urine pretty much as quickly as it's made. So in this case, the normal kidney has picked up the urine or the tracer and started excreting it well before the Lasix is given, which is here at the 20-minute mark. So on those scans, there's usually a blue line or some other demarcation at the time that they gave the Lasix. So classically, it's supposed to be done at 20 minutes, but sometimes you'll see that they will give it sooner than that. So the obstructed kidney in the blue dotted line here, so it's just picking up tracer, picking up tracer, picking up tracer. And then they give the Lasix, and there's a little bit of excretion of the urine, but not substantially. So the amount of time how you calculate the T1/2 is actually after this 20-minute Lasix time. So whenever the Lasix is given, that's when you start calculating these numbers. So you actually have to look at these pictures yourself in the radiology study, because you might be surprised at how many even radiologists read them incorrectly, where it might not be a huge deal for trying to differentiate a clearly obstructed kidney, but there are certainly other types of kidneys that are dilated but not obstructed that it matters. So, sorry, I'm rambling here. So the Lasix is given, and that's actually your T0, if you will, for calculating this. So in this kidney that's unobstructed, the amount of time for half the tracer to exit is really not pertinent, because it's already mostly excreted over here, right? But this kidney, you're looking, and for it to excrete half the tracer, it would be down to about right here, and it never hits that mark in the 20 minutes that are being imaged after the Lasix here. So the T1/2 here is greater than 20 minutes. So this is an obstructed kidney. Does that make sense? Any questions? I can pause if anybody has questions about this. I think this is pretty pertinent. Pipe up if you do. I can't see the chat, so Dan, if there's anything in the chat, let me know. Nope. Okay. So again, the differential function is calculated in that first 1 to 2 minutes when the tubules have started picking up that tracer. Normally, kidneys should be splitting the work 50-50. And I also wanted to point out that the radiation dose of a Lasix renal scan is pretty low, 0.7 millisieverts on average is the reported amount. A CT scan, old school CT scan is about 10 for comparison's sake, less with today's modern scans. But other thing to be aware of, a Whitaker test is also a gold standard test to evaluate for obstruction. This is the test that you use if it is unclear to you if it's equivocal, whether there's an obstruction. So how you perform this test is you need 2 sites of access to the urinary tract, one of which is a Foley catheter with a manometer or a pressure sensor. And then you also will put either an nephrostomy tube, or you can percutaneously, radiology does these studies, they can place a needle into the kidney. And then you start infusing normal saline at a rate of 10 milliliters per minute. So slowly dripping it in. And there's also a manometer up at measuring the renal pelvic pressure. And so again, the urine should drain as quickly as it's made, essentially. So the pressure should stay nice and low throughout that entire study, compared to the bladder. So the bladder is stretchy, that's sort of your baseline 0 abdominal pressure. And then you measure how much the pressure is building up in the kidney. And again, there are numbers here. I have seen those on in-service exams, so might be worth trying to remember. But essentially, if it's not building up pressure, then it's unobstructed. There's again an equivocal range, and then greater than 22 centimeters of water, that's obstructed. There are other studies that can be helpful for figuring out if somebody has UPJ obstruction. Classically, they did an IVP that would show delayed nephrogram and delayed drainage. Retrograde pyelography can also help delineate the site of obstruction for surgical planning. Renal ultrasound, especially in a pediatric population, and ureteroscopy if you're trying to figure out if there could be a tumor or some other cause of obstruction. So take-home methods on imaging. Diagnosis of UPJ obstruction requires really the surgeon to integrate the constellation of how this patient's presenting, what their symptoms are, and what the radiographic studies are telling you. So who needs treatment or intervention for UPJ obstruction? Like many things in urology, not everybody necessarily needs treatment, which we'll talk about more. But patients who probably do merit intervention, patients who have the classic obstructive symptoms, also patients who have impaired renal function, or who have been followed over a period of time, and you see on those follow-up Lasix renal scans that the amount of function in the affected kidney is declining over time. And then patients who are having stones or infection that you think are related to the UPJ obstruction. And then finally, rare in all but consults from nephrology and internal medicine, causal hypertension is a theoretical side effect of UPJ obstruction in some patients, rarely. So what are the goals of intervention? To relieve symptoms as well as to preserve renal function. So again, as in many things in surgical fields, you have options of watching or doing surgery. And surveillance actually can be a reasonable option in quite a few patients. So as mentioned, a lot of patients may present with incidental finding of hydronephrosis related to UPJ obstruction on an imaging study. And they may never have had symptoms even when they look back in retrospect. Cenk Gürbüz, a colleague and friend from Turkey, when I was a fellow, did a study looking at a series of patients who had been asymptomatic, had had only one pain episode prior to presentation for UPJ obstruction. And they found in a retrospective study that only 30% of patients who had a decline in renal function or worsening pain symptoms in a follow-up of 4 years under observation. So again, the other option is surgery. So surgery for UPJ obstruction, that we have a variety of options, some of which are endourologic, and the others are typically pyeloplasty, and we'll talk about all of these. Under others, we also have the possibility of nephrectomy, which we would typically consider for patients with a function of less than 15% or less than 20% function. And part of the reasoning for that was that classically, even, I would say until recently, it has been taught that you don't want to do a pyeloplasty on a poorly functioning kidney because the outcomes will be worse. I think we thought that there's less urine being made by that kidney, less draining through that reconstructed UPJ, and that it was more likely to stenose. So people tended to either observe or jack those kidneys if they were poorly functioning. But if there has been a change in UPJ obstruction in the last decade, I would say that this is the area of that. So a few small studies have found that when they have done pyeloplasties on poorly functioning kidneys, they can actually have pretty good outcomes. So again, another study out of UT Southwestern, a large series of 139 patients with pyeloplasty. 15 of them had a poorly functioning kidney, and 3 of them had improvement in their function after the surgery, and there was no difference in failure rates after pyeloplasty. Another similarly sized series, 15 out of 224 pyeloplasty patients had poor functioning. They found a small improvement in function after pyeloplasty, and again, no difference in failure rates. So I would say that we are steering more these days towards considering fixing these kidneys if they have sort of that borderline function. If there's hardly any function whatsoever, it probably still is not worthwhile. But if it's sort of that 20%, 15% function kidney, you might want to consider it. So another quiz question. The highest failure rate in treating UPJ obstruction is associated with antegrade endopyelotomy, retrograde ureteroscopic endopyelotomy, balloon dilation, pyeloplasty, or cautery balloon incision. And the answer is balloon dilation. If you just stretch that area, that almost never fixes it. If you think about the potential causes that we reviewed, a crossing vessel, a stricture, or a high insertion or aperistaltic segment, it makes sense that's not likely to fix any of those issues. So endopyelotomy is a procedure in which an incision, longitudinal incision is made in the ureter at the UPJ to open this area up, essentially hoping to create a scar that is wider than the UPJ at baseline was. This can be done either in an antegrade approach through a percutaneous access or a retrograde ureteroscopic approach. Antegrade is particularly useful if patients have concomitant stones. So if you're doing a PCNL for large stones in a patient who has a UPJ obstruction as well, you could consider also doing a endopyelotomy at the same time while you're in there. So classically, the indications for endopyelotomy were for patients essentially who you didn't want to do a pyeloplasty on. So patients who are poor surgical candidates that you didn't think were likely to do well with abdominal surgery, people who are older or sick or have had prior abdominal surgeries. Or there are some people who might say, I want the least invasive surgery with the fastest recovery time, no matter if that comes at the cost of a lower success rate. But probably, well, not probably, for sure, the best indication is for a secondary UPJ obstruction. The highest success rates in endopyelotomy are in patients who had a pyeloplasty and developed fibrosis or scarring, narrowing at that site. If you incise that, that has a pretty high success rate. So how might you pick patients that might do better, I'm not going to say well, but do better with an endopyelotomy than others? So there are definitely have been some studies looking at predictors for success, and they make a fair bit of sense, I think. So patients who do not have a crossing vessel are going to do better from an endopyelotomy than those who do have one there. That makes sense. Again, you're not moving that vessel or necessarily addressing the underlying issues if you just do an incision. Low-grade obstruction versus high-grade obstruction does better. And finally, as in any ureteral stricture case, success rates for endourologic intervention are better the shorter the stricture is. Advantages of endopyelotomy: it has a short procedure time. It's an outpatient procedure. with low morbidity, and it doesn't matter how many surgeries the patient has had previously. You're not going into their abdomen, so it doesn't matter. In order to place these to do these procedures, whether you're going antegrade or retrograde, you are going to place the safety wire, and then the incision in the ureter is classically going to be performed in the lateral aspect of the ureter, because you would anticipate there's not a vessel there, hopefully. And the reason I'm not really showing pictures of doing endopyelotomy, it's difficult to show without video, and there aren't a ton of great videos online to show this. So we should, next time we do one of these, we should try to record. So there are, of course, a variety of series out there that have looked at success rates after endopyelotomy. And they have a varying level of success and a varying amount of follow-up. And I'm mentioning this mostly because I think that the literature on UPJ obstruction is a great example of how important it is for us to be careful consumers of the medical literature. So you have to read how the studies were done, what their outcome measures were, and what their follow-up time periods were. So in these studies, for example, the definition of success. So we have just these percentage. All you're going to see in the abstract probably is what their quote success rate is. But if you delve into the weeds of the methodology of these studies, their definition of success is extremely variable. So in some people, in some studies, their definition of success is symptom relief. So if they don't have episodes of flank pain, or don't go to the ER with flank pain during the follow-up interval, then they're considered a success. And then there's a wide variety of imaging studies that can be used to define success as well. So we might think that you would probably want to require a Lasix renal scan or a Whitaker study or something like that to say that, aha, we have a success. But that's often not the case. It may just be recommending improvement of hydronephrosis or seeing improvement of hydronephrosis on a follow-up renal ultrasound. So I'm not sure that that would necessarily be a true success either. So make sure you read the literature. Same kind of deal, percutaneous endopyelotomy, the ones that are done through a percutaneous access. Some degree of longer follow-up here with a wide range in success rates. And again, it's thought, as with most surgeries, but especially for endopyelotomy, the further out you follow patients, you're going to see a significant drop in the long-term success rates. I will mention one slide about cautery wire balloon endopyelotomy. I think we are planning to actually remove this from the chapter in Campbell's that Dr. Mikata and I do, because really, I don't even know if you can get these anymore, but it's worth talking about. It was a blindly or just fluoroscopically done study where you would put this hot wire balloon. Essentially, it's like one of our ureteral dilating balloons, but it had a cautery wire on the side, and you would try to position it across the UPJ, set the cautery to super high on your Bovie machine, and fire her up under fluoroscopic guidance. And there's a wide range of reported success rates on this, but the real problem was that 7% of these patients had needed a blood transfusion or angioembolization, because you might get into serious bleeding. So we don't do that really anymore. And most endourologists for quite a few years now, if you're planning to do an endopyelotomy, you can do it under direct vision with a laser, and therefore the idea being that you can see what you are cutting and hopefully stop before you cut into that big pulsing thing. Another question, the condition most predictive of failure after percutaneous endopyelotomy is moderate to severe hydronephrosis again. So the degree of obstruction is felt to be associated with endopyelotomy success rates. So summary slide here, the endourology options for UPJ obstruction are listed here. Probably somewhere between the 60 to 80% success rate. with these options. And that's not spectacular. So in the last few minutes, we'll talk about pyeloplasty, which is considered the gold standard. So there are a variety of ways to reconstruct a UPJ, but the classic variation is shown in the pictures here, and that's a dismembered pyeloplasty, which can be used to reconstruct a variety of problems at the UPJ. This can be done open or laparoscopic robotically, and is the gold standard. So with the evolution of minimally invasive pyeloplasty, this has really taken off, and the morbidity of these procedures has significantly decreased. In the first decade of the 2000s, this went, the amount of procedures being done minimally invasively went up dramatically, and the majority of these are done robotically. But it is interesting that 40% of the pyeloplasties performed between 2002 and 2010 were still done open. Advantages of pyeloplasty: it works really well and it's adaptable to a variety of anatomical situations. So you have one operation that can fix the majority of the problems at the UPJ. It can address lower pole crossing vessels if you do a dismembered pyeloplasty. It can address strictures and high insertions by reconstructing all of those problems and making a new drainage site. Minimally invasive pyeloplasty was first described in 1993, and initially, if you look back in the literature, there's a fun series of editorials about whether or not this was going to take off or not, and certainly suturing laparoscopically to do these is challenging to learn, but it works great in hands that are used to it, and especially the robot has made this dramatically easier. So there were, again, a lot of studies looking at comparing laparoscopic and robotic surgery. Again, we're not going to go through all of this, but I wanted to again point out that you got to look at the study that you're reading to make sure if it's really a good study. The follow-up in a lot of these is pretty short, 5 months. I don't know if you can determine that a procedure, other than saying, hey, we didn't hurt anybody, is a successful study. But then also the success rates, their definition can vary. So strict success, for example, in the Winfield study was a good non-obstructed Lasix renal scan plus the absence of pain. So the 100% of patients had improvement on Lasix renal scan, but only 64% had no pain. So there are also some interesting, thankfully less common situations for UPJ obstruction that you might have to deal with. There are patients who have essentially an obliterated renal pelvis that is very hard to access to suture to. And so in theory, you can do a ureterocoelocostomy where you anastomose the ureter to the lower pole, which looks super beautiful and easy to do in this picture here. But as you can imagine, if you cut across the kidney's lower pole here to expose a calyx, it's not going to look like this beautiful flat surface here. It's going to be hemorrhaging, so you have to essentially do a partial nephrectomy and sew it to that. So that can be challenging. There are other reconstructive options such as spiral flaps from the bladder or bowel interposition that can help address long stenoses. And then, of course, secondary UPJ obstruction is well dealt with a endopyelotomy. Failed pyeloplasty. Typically, the endopyelotomy works well, greater than 70% success rate. If that does not work, redo pyeloplasty can be done, and thankfully also has a high success rate. So I think the take home there is if you do an endopyelotomy on a failed pyeloplasty, your next step probably should be a redo pyeloplasty. And similarly, if you've done a primary endourologic intervention and that fails, then you would want to move swiftly on a pyeloplasty. So how do we follow up patients who have undergone a pyeloplasty? Usually the stent is left in place 4 to 6 weeks after the procedure in adults. Then we have them come back in about 1 to 2 months for symptom assessment after the stent removal and a repeat diuretic renography study to get a new baseline. And then I repeat that in patients, having them come back at 6 months then yearly after that for a few years, and most of the failures occur in the first 2 years. So you'll catch most of them in that time. So overview of UPJ obstruction treatments, success rates highlighted here. So the pylotomy options here, lower success rates, probably even lower than some of these numbers suggest in terms of true long-term treatment of obstruction, and pyeloplasty having a pretty darn high success rate. So take-home message, there are thankfully many minimally invasive options. Patient factors may help you determine which is the best option for an individual, and pyeloplasty probably has a 10 to 30% higher success rate than endopylotomy. And one last picture of my cute dog who was very good during the talk. Thank you very much. Anybody have any questions?
Awesome. Thank you so much, Dr. Best. There were a few questions, comments in the chat. Maybe that could be a quick thing to address before we kind of open up the floor for questions or discussion. One question was from Dr. Sorrell about endopylotomy. How long do you leave a stent in after endopylotomy?
Yes. Sorry, I'm trying to get this to come up here, and it is, let me see if this works here. Another meeting, some process. Nope, I don't know what happened, sorry. I'll just talk, so you'll have to read them to me, sorry. Can I click this and stop sharing? Okay, share. Stop sharing. Like, oh, thank God. Okay, sorry guys. So after an endopylotomy, usually I would say leaving it in about 4 weeks, I think is probably the safe option there. I think another good question is, should you leave a Foley afterwards? And so I think, for example, Dr. Pearl would leave in a Foley afterwards for about 48 hours. That kind of makes sense. You even all the urine that you're draining from the contralateral side could theoretically then reflux up the stent and go out your incision if you don't have a Foley in place. The tricky part I've always thought there is, why do we think at 48 hours that suddenly gets better? So when, you know, are you going to leave in a Foley for a month? No. So I think it's sort of an unknown as far as that goes. Let's go to.
There was another question about the 20% function rationale about proximal ureteral strictures. If the ureter is ultimately going to end up in an ileal ureter or an auto transplant.
So you mean, so like not a UPJ obstruction like from a crossing vessel, but like a different etiology of obstruction of the ureter in the proximal ureter? I would say that's trickier to know. Probably, I would say. I don't know that we know. I don't know if there are series out there showing good success rates after doing surgery on a poorly functioning kidney with a 20% function. I guess I don't know the answer to that, because probably one of the advantages in patients who have a UPJ obstruction, their comorbidities or the cause of their obstruction is probably more favorable, if you will. It's an anatomical, factor such as a crossing vessel, whereas their, tissue quality or overall renal function, people who have bladder cancer, for example, might have more issues with their ability to heal or their renal function. So I think the answer is we don't know.
That was not a fair question. I'm sorry, Dr. Best.
That's okay. I love all questions. I will always entertain any question from you, Dr. Richards.
The reason I thought it made me think of sort of the non-UPJ patient population, right? That we see that have these sort of nasty proximal ureteral strictures, and
The worst.
I think your answer is spot on, though. Is it's a different patient population, so I think the 20% may not. If you've got a kidney that has less than 20% function and it's not a UPJ, we don't have data on those patients, and their kidneys may not bounce back quite as fast as the sort of UPJ kidney.
Yeah, I think also the proximal ureter is the most delicate and terrible part of the ureter. And I think, you know, for a UPJ obstruction, I think the renal pelvis has a better blood supply. So if you're suturing the, you know, proximal ureter to the renal pelvis, you probably have a better blood supply there than proximal ureter to proximal ureter, for example. And it's just oftentimes they're longer than that. I've certainly been sent patients with proximal ureteral strictures, hoping for an endoscopic incision, and it's, you know, they just don't work very well. So that's part of why I am a bit of a chicken, if you will, about impacted proximal ureteral stones, and I will be quick to place a stent and come back another day, because there's just no proximal ureter like your original proximal ureter. Ilio-ureter patients are not always delighted either. So, okay, nuclear medicine, LASIK scans, other than patients with bladder obstruction, who benefits from a catheter during the study? Also a good question, Emmy. I will also direct people to the core curriculum on AUA website. The AUA University has a really good discussion of this particular topic on the imaging portion, so the radiology contributed portion of the core curriculum. So really anybody that is going to have a high bladder pressure should have a Foley placed during their study, or if you're just not sure. So I think the default classically for nuclear medicine scans, looking at the kidneys, is to place a Foley. So if the bladder has high pressure, that may prevent antegrade flow from the ureter or kidney into the bladder. So patients who have a neurogenic bladder or other type of high pressure bladder, those are people that you want to consider putting in a Foley. Oh yeah, and McGackern answered that. Yes. I should have just let Dr. McGackern answer it, because that was, of course, better said than I would ever say. Great questions. Anybody else? Feels like enough. Thank you, everybody. I will look forward to seeing the residents during rec with some terrible 24-hour urines to torture you with. Look forward to that.
Well, that's great. Well, yeah. Well, thank you, Dr. Best, for your presentation this morning. Thank you in advance for your time with the rec later this morning. And we will leave this WebEx and go over to another WebEx for our Red-Blue Indications Conference. All right. For those who we won't see on the Indications Conference, have a great 2/2/22 day. See you soon.